Welcome back, everyone. Let's jump right into this rapid-fire explainer covering some absolute high-yield pediatric clinical and surgical essentials. We're going to move fast, so buckle up.
Here's our fast-paced roadmap for today. We'll be hitting neonatal GI, surgical timings, abdominal malignancies, head and neck issues, BSORs, and finishing up with orthopedic essentials. Let's get to it.
Okay, first question. We have a newborn with a maternal history of polyhydramnios who presents with excessive salivation, coughing, and choking right on that first oral feed. An X-ray shows gas in the stomach and a coiled NG tube in the esophagus. So, what's our most likely diagnosis here? Is it A, esophageal atresia, B, TEF, C, EA and TEF together, D, omphalocele, or E, gastroschisis?
And the correct answer is C, esophageal atresia combined with a distal tracheoesophageal fistula. Specifically, this is describing type C, which actually makes up about 85% of these cases. The pathophysiology totally explains the presentation here. See, maternal polyhydramnios happens because the fetus literally can't swallow amniotic fluid. Then, at birth, fluid just pools in that blind proximal pouch, which causes the choking. Meanwhile, that distal fistula allows air from the trachea to go straight into the stomach. For your exam pearls, always check for the bacterial association with these patients. And remember, type A is completely gasless, while type E usually presents much later with recurrent bouts of pneumonia.
Moving right along to our next question. What will be the caloric requirement in a child weighing exactly 10 kilograms? Are we looking at A, 80 kilocalories per kilogram per day, B, 90, C, 100, D, 110, or E, 120 kilocalories per kilogram per day?
The correct answer is D, 110 kilocalories per kilogram per day. You know, pediatric maintenance requirements are strictly mapped to body mass. For infants up to 10 kilograms, they need a baseline of exactly 110. But notice this really sharp drop-off. For weights above 10 kilos, that requirement falls to a range of 40 to 75 kilocalories per kilogram per day. This happens because their relative basal metabolic rate actually slows down as they grow.
Okay, next up. What is the adequate time interval for an orchopexy in a palpable, undescended testis? Is it A, before 2 months, B, 3 to 4 months, C, 6 to 12 months, D, after 4 years, or E, after puberty? The correct answer here is C, 6 to 12 months. The general rule is if a palpable testes hasn't descended by 3 to 4 months, it's just not going to descend on its own. Pediatric surgery relies on some incredibly strict timings. For instance, congenital hydroceles are observed until repair after 3 years of age. Testicular torsion requires emergency detorsion within 6 to 8 hours, literally a race against the clock to prevent ischemic necrosis. Hypospadia's reconstruction falls in a 6 to 18-month window. And biliary atresia, that demands an urgent Kasai-Porto-enterostomy strictly before 8 weeks of life.
Let's look at this next clinical vignette. A 3-year-old boy is brought in. He's asymptomatic, but his mom noticed a smooth, firm flank mass during his bath. On exam, the mass does not cross the midline, and his blood pressure is 105/85. What's the most likely diagnosis? A, desmoid tumor. B, squamous cell carcinoma of the kidney. C, Wilms tumor. D, Grauwitz tumor. Or E, Ewing sarcoma.
If you guessed C, Wilms tumor, also known as nephroblastoma, you hit the nail on the head. This is the most common primary renal malignancy in kids, and it classically presents just like this, a fixed lateral mass. Now, you might be wondering about that high blood pressure. About half of these children have systemic hypertension because the tumor mechanically compresses the renal artery, directly activating the ROS pathway. For your exams, definitely maintain a high clinical suspicion for Wagner and Beckwith-Wiedemann syndromes, and always get a Doppler ultrasound to check for an IVC thrombus before they go in for a radical nephroureterectomy.
Following up on that, which feature differentiates between neuroblastoma and Wilms tumor, considering both are childhood malignancies with kind of similar presentations? Is it A, urinary catecholamine levels, B, CT abdomen, C, MRI abdomen, D, chest X-ray, or E, ultrasound abdomen?
The answer is A, urinary catecholamine levels. You see, over 90% of neuroblastomas synthesize and secrete excessive catecholamines, making urinary VMA and HVA the absolute definitive biochemical markers. The clinical contrast between the two are pretty stark when you break it down. Neuroblastoma originates from the adrenal lobula or sympathetic chain, acts as an irregular mass that crosses the midline and leaves the child looking toxic and febrile. Plus, you'll see Homer-Wright rosettes on histopathology. On the flip side, Wilms tumor originates from the metanephric blastema, remains lateral, happens in a healthy-appearing child, has normal catecholamine levels, and shows a triphasic pattern on histology. Next question. Which of the following is the primary cause of congenital torticollis? A. Accessory cervical rib. B. Congenitally narrow thoracic inlet. C. A large neck tumor. D. Damage and fibrosis of the sternocleidomastoid muscle. Or E. Spasm of the trapezius.
It's D. Damage and fibrosis of the SCM, or sternocleidomastoid muscle. Basically, intrauterine malposition or localized birth trauma creates a localized compartment syndrome right in that muscle. This ischemia directly causes dense collagenous muscle fibrosis and shortening. Anatomically, this pulls the baby's head into an ipsilateral tilt with a compensatory contralateral rotation of the chin. When you examine them, look for a palpable, firm, olive-like mass in the neck. And keep in mind, this condition is heavily associated with concurrent developmental dysplasia of the hip.
All right, let's check out this next scenario. A baby is born with a raised mass below the scalp. What is the most likely diagnosis here? A. Hemangioma. B. Port wine stain. C. Raspberry tumor. D. Strawberry tumor. Or E. Hematoma.
The correct answer is E. Hematoma. Specifically, we're talking about a neonatal cephalohematoma, caused by the rupture of emissary veins. Because a cephalohematoma is trapped tightly beneath the periosteum, it is strictly limited by the cranial suture lines. It literally cannot cross them. Over time, it can actually calcify into a dinner plate deformity. You really need to contrast this with caput succedaneum, which is superficial subcutaneous fluid that does cross sutures and resolves rapidly. Also, compare it to the very dangerous subgaleal hematoma, which bleeds into the loose areolar tissue beneath the galea, crosses sutures, and can hold a massive volume of blood, putting the newborn at a huge risk for hemorrhagic shock.
Moving on, a 12-year-old child with developmental delay presents to the emergency department with severe abdominal pain. An ultrasound shows an intraluminal mass right in the stomach. Diagnosis? A. Bezoar. B. Hypertrophic pyloric stenosis. C. Gastric lymphoma. D. Gastrointestinal stromal tumor or GIST. Or E. None of the above.
The answer is A. Bezoar. A bezoar is essentially a tightly packed mass of undigested foreign material stuck inside the GI tract. In a child with developmental delay experiencing severe pain, this highly suggests a trichobezoar. That comes from chronic trichophagia, or compulsive hair swallowing, and hair just totally escapes enzymatic digestion. A couple of exam pearls to memorize: if that mass extends past the pylorus and into the small intestine, we call it Rapunzel syndrome. There are also phytobezoars, which are made of vegetable fibers, usually seen in patients with gastric stasis. Both of these can cause devastating complications like mechanical obstruction or frank visceral perforation.
Let's look at some orthopedic essentials. A child is diagnosed with bilateral developmental dysplasia of the hip, or DDH. Which of the following will be seen? A. Short stature. B. Unable to squat. C. Waddling gait. D. Inability to walk. Or E. None of the above.
The correct choice is C. Waddling gait. Here's why. Bilateral structural instability completely disrupts the normal balancing function of the gluteal muscles. This bilateral gluteal mechanical disadvantage literally forces the child to lean their torso toward the weight-bearing side with every single step. This creates an alternating lateral torso shift, which we see as a waddling gait. Keep in mind, unilateral DDH presents a bit differently, usually with an asymmetric limp or a positive Trendelenburg sign. Risk factors are super high in female infants. They make up about 80% of cases, as well as in breech presentations. And remember, left untreated, this chronic joint misalignment guarantees premature degenerative osteoarthritis.
Next question. Which investigation is the absolute choice to screen at-risk babies for developmental dysplasia of the hip at exactly 6 weeks of age? A. Ultrasound. B. X-ray. C. CT scan. D. MRI. Or E. Clinical assessment using the Ortolani and Barlow tests.
It's A. Ultrasound. In infants younger than 4 months, the femoral head and acetabulum are predominantly cartilaginous and radiolucent. That means they just won't show up clearly on a standard plain X-ray. So, a dynamic musculoskeletal ultrasound is the definitive tool at 6 weeks. For your exam pearls, clinical screening uses the Barlow test to attempt to dislocate the hip and the Ortolani test to attempt to reduce it. X-rays really only become reliable after 4 to 5 months of age. As for management, a dynamic positioning device, like the Pavlik harness, is highly effective for unstable hips if you initiate it early.
All right, our last question. What is the initial management for a flat foot? A. Orthoses. B. Medical management. C. Surgical management. D. Calcium supplementations, or E. None of the above?
The correct answer is A, orthosis. Now, a painless, flexible flat foot usually requires no active treatment, but if the patient develops pain or postural fatigue, your initial management relies on conservative, custom foot orthosis. These arch supports are great because they cushion the foot and crucially redistribute mechanical forces to relieve symptoms. Just make sure to note that they don't structurally reshape the permanent bone anatomy. Finally, always make sure to rule out structural anomalies, like a tarsal coalition, if you happen to encounter a flat foot that is rigid rather than flexible.
And that brings us to the end. So as we wrap up, I want to leave you with this to think about. How does the rigid, unforgiving timeline of anatomical development dictate our exact clinical and surgical interventions across all pediatric specialties? Thanks for joining me on this rapid-fire explainer. Keep studying hard, and I'll catch you next time.